evening. I hope and I believe all of you are doing well. A quick note whether the audio visual is all good. Am I audible and visible now? Yes, that's great. So here we are in the IPL T20, basically the series of sessions on an Academy YouTube channel, where the respective educator is discussing the most important topics and the most expected topics in their respective subjects. So here we are today to discuss the radiology most important images, right? So I hope all of you are ready to quickly have a quick look at these images. I have shared the PDF. No, I have not shared the PDF on the Telegram group. So I would do that after the session is done. All right. And before we start with the class, a few updates about the platform, what's happening on the platform. So till April 15, we have flat 20% off on all the Unacademy Medical PG subscriptions, where we have the most important, the NEET PG 24 batch going on, the aim students who are preparing for the next year NEET PG exam. And here the combo offer, that is the live and the vitals together. The live is the live classes, vitals is the recorded classes. Here you get it at around 19K, right? And along with that, you get the notes also free if you take the subscription for 9 months or above. And this offer, that is 20% off, is available till April 15th. And you need to use a code to get this discount basically. So you can use the code Dr. Nikita or any other code. Okay? Yes. Thank you so much, Meddomic. I do remember you from the classes, I believe, a very, very familiar name. All right. And so this is the schedule that we have for the IPL, that is the INI-CET Premier League, the T20, the top 20 topics that is going on. So today we have radiology. Then tomorrow and day after at 7 p.m., you are going to have the ENT sessions, right? And then would be medicine, anesthesia, pediatrics, and physiology. So this is going on till April 20. Apart from that, remember that 20% off is on all the medical PG subscriptions. So now this is also available on the short INI-CET course that we had offered. Right. So what do you get with this is now with the offer that is running on till 15th of April, you would get the short INI-CET at around 4K after using the code. So you need to access that short INI-CET, even the students who are not like dedicated plus subscribers. You can get this from the Unacademy store option. Okay, you would get an option of store. Right. And next one, we also have the FMGE preparation, the last mile FMGE batch, also available on the Unacademy store. That is there, right, which has 3 months of course through 200 plus hours that we have at 4399. And we also have the Pathomicropants by Dr. Preeti, which is there on the Unacademy store. Yes, so I am actually, honestly to tell you, I'm not a person who's too much into like, the counseling stuff and the news related to counseling. So I would say sorry for that. Not the right person to answer your question to this. Azhar, necessary to read notes or only diagrams are important? Notes, are you talking about radiology specific or only like for all subjects? Most important, I would say, is practicing the MCQs. Oh, thank you so much, Shambhavi. That's a very, very important topic for your upcoming exam, cancer staging. All right. And what do we have? Another thing today that is coming up, another session that we have is in the short INI-CET course. That is basically for the subscribers. The class that we have today is at 8 p.m. And it's basically going to be like another fast episode today. Today's short INI-CET would be basically based on first aid, right? Some snippets from first aid is what we would have. Also, we are having the INI-CET All India mock test, which is coming up on April 16th at 9 a.m. Right? So make sure you make the best of all these opportunities. So starting with the discussion, short INI-CET enough, or we have to read short 150 notes again? Diksha, you have to do that as well, right? Because I am not including the topics that we have done in short 150, the NEET PG wala, in the short INI-CET. Again, because of the limited time from my end as well, right? So you have to watch that for sure, because in the last INI-CET, like I mentioned, from those 150 topics, there were around 50 plus questions. Right, there were around 50 plus questions, so you need to watch that for sure. Vandana, today's short INI-CET is 8 p.m. Okay, all right. So starting with the first topic here, nuclear scans is important for INI-CET exam. Nuclear scans is important, and so the most important question in nuclear scans that is asked in almost all the exam, be it INI-CET, be it FMGE, be it NEET PG, for parathyroid adenoma, what is the scan used? So for parathyroid adenoma, the scan used is SYSTA-MABI scan. Right, very, very important. And what are generally the features that are given in parathyroid adenoma or hyperparathyroidism? Right, what are the features given in hyperparathyroidism? Remember, it is stones, bones, groans, and moans. Right, those are the features. So there are renal stones, hypercalcemia, calcium deposition, there are renal stones, bone pain, abdominal pain, and psychiatric features is what we have. So when you have these constellation of features, you should think of hyperparathyroidism. With parathyroid adenoma, the calcium would increase, the phosphorus would decrease. It causes opposite effects on calcium and phosphorus. Right. What is MIBG scan used for? MIBG scan is used for pheochromocytoma. For pheochromocytoma, we also have the DOPA PET, right? We also have the DOPA PET for pheochromocytoma. SRS is somatostatin receptor scintigraphy, which is basically done for neuroendocrine tumors. But remember that it is negative for which neuroendocrine tumor? It is negative for insulinoma. Okay, it is negative for insulinoma. Now for neuroendocrine tumors, what do we use? The DOTA-NOC, the DOTA-TOC PET basically is what we use for the neuroendocrine tumors. Thallium scan is the most important, this is for myocardial perfusion, myocardial ischemia. So ischemia basically will give a reversible defect. A reversible defect is what we would see with myocardial ischemia, right? And what is the scan that we use for the bones? What is the bone scan? What is the bone scan? Bone scan is technetium 99 MDP. Remember, we use MDP for the bone scan. And what is HIDA for? HIDA is basically for the biliary tract. Remember, it is the most sensitive investigation for bile leak. It is the most sensitive investigation for bile leak. Okay. All right. Going to the next one. Tell me what would be the answer to this. Which of these is used for ejection fraction? Which of these is used for ejection fraction? This is a previous INI-CET, and also this is a question that has been asked in FMGE exam also. Ejection fraction is the MUGA scan, right? Remember, it's the MUGA scan. MUGA stands for multiple gated acquisition. Okay, MUGA stands for multiple gated acquisition. This is the scan which is used for ejection fraction. That's basically the left ventricle function, right? That's the left ventricle function. And if the question is, what is the most accurate for the left ventricle function? What is the most accurate for left ventricle function? Very good. The most accurate is cardiac MRI. Okay, the most accurate is cardiac MRI. Okay, and PET is the best for viability. For viability, basically to look for hibernating myocardium. For that, PET is the best. Okay, for that, PET is the best. Echo is not the best for myocardial viability. It might give false positive results. A hibernating myocardium will not contract on echocardiography on ultrasound because it is sleeping, it is hibernating. So it looks like an infarct, but actually it's not an infarct. So PET is the best for myocardial viability. Okay, look at this one, the thyroid scan. What do you think is the diagnosis in these two images? Thyroid scan. So when we have diffuse increased uptake, this is very, very black, entire black. Ruchika, you need to increase the resolution from your end. Go to the settings, the options, and increase the video quality. Right. When it is diffuse increased uptake, the hot spot, that is the Graves' disease. When there is hardly any uptake in the thyroid, you can see there are no black areas, there's hardly any uptake. Then it is the thyroid burnout that is basically seen with thyroiditis. Thyroiditis causes the burnout. So remember, diffuse increased uptake is Graves and diffuse decreased uptake is thyroiditis. We use iodine 123, which has half-life of 13 hours, and per technique scan can also be used for thyroid. Next one. Now, the next important topic here is generally the question is asked, which is the most sensitive and which is the most resistant various areas. Which is the most radiosensitive cell cycle phase? G2M. Which is the most radio-resistant? S. Which is the most sensitive tissue? Tissue most sensitive is bone marrow because it is continuously dividing. Most resistant is the neurons because they do not divide. Blood cell most sensitive is lymphocyte. Lymphocyte is the most sensitive blood cell. Platelet is the most resistant blood cell. Tumors, which are the most radiosensitive? It is Wilms that you need to remember for the most radiosensitive. Wilms stands for Wilms, Ewing's, lymphoma, right? Multiple myeloma, remember it's not melanoma, and S for seminoma. Which testicular tumor is radiosensitive? It is seminoma, and the ovarian counterpart of that is dysgerminoma. The rest of the testicular and the ovarian tumors are radioresistant. Right, which are highly radioresistant? Remember MORPH. MORPH is highly radioresistant. What does MORPH stand for? MORPH stands for melanoma, osteosarcoma, RCC, pancreatic, and HCC. Okay, that is what MORPH stands for. Remember that it is MORPH and we have Wells. Okay, Wells and MORPH is what we have. Next one, now coming to the discussion of Pyrads and Tyrads. All of us know that we have Pyrads, which is for breast imaging, reporting and data system. It applies on mammography also, ultrasound also, and MRI also. Now, one of the questions asked in the Central Institute exam was on Pyrads, which is basically for prostate and the evaluation of prostate nodule on which investigation? It is on MRI. Okay, it is on MRI. And the question was, which of the following MRI sequences not included in Pyrads? So remember that MR spectroscopy does not form the part of the Pyrads scoring. We have T2, we have diffusion weighted imaging, and we have dynamic contrast enhancement, which are included in the Pyrads evaluation. It is not the MR spectroscopy. Prostate cancer is T2 hypo-intense. Like generally we read that pathologies are hyper-intense, but remember that CA prostate is T2 hypo-intense, restricted diffusion, early wash-in, wash-out is what we see on contrast scan. Okay. So for the transition zone, it is determined by the T2 weighted imaging, and for the peripheral zone, it is the DWI. Okay, the DWI is what predominantly used. So remember, MR spectroscopy does not form a part of Pyrads. Next, another question on Tyrads. What is Tyrads for? Tyrads is for thyroid. The evaluation of thyroid nodules on which modality? It is the evaluation of thyroid nodules on ultrasound. Okay, that is on ultrasound. So, what do we do for this one? The question asked here was, what is not included in Tyrads? Remember, it is not the Doppler evaluation or the vascularity involvement is not included in Tyrads. What are the components? It is the composition, that means whether the lesion is solid or it is cystic, hypoechoic, hyperechoic. Is it wider than taller or taller than wider? That's the shape. How is the margin and how are the echogenic foci within? Right. So basically remember that vascularity is not there. Which features are suggestive of a malignant tumor? A solid lesion, A hypoechoic lesion, not a hyperechoic lesion. Anechoic is 0 because anechoic means a cystic lesion. Remember, the majority of the malignant lesions, they are taller than wider. That means they are invading the planes. So that is why they are taller than wider rather than wider than taller. Applies to breast cancer also. It has extra thyroidal extension, and the punctate echogenic foci are the one which are suggestive of malignancy. Comet tail artifact is 0. Comet tail nahi, macro nahi. It is punctate, like you have in breast cancer microcalcification. Here also the punctate echogenic foci are highly suggestive of malignancy. So remember, a solid lesion, a hypoechoic lesion, which is taller than wider, which has lobulated margins with extra thyroidal extension, and which has punctate echogenic foci. All these are the features which are given higher points for identifying a thyroid malignancy. Okay. And if it is TR5, that is highly suspicious. If the lesion is 0.5 centimeter, less than 1 centimeters, we need to do follow-up. If more than 1 centimeters, then we need to do FNAC. Okay, then we need to do FNAC. Next one. Now, the next important topic here for INI-CET is the radiology of the PNS, the paranasal sinuses. Remember, for CT PNS, for paranasal sinuses, CT is the investigation of choice, right? So before FES, ideally we do CT scan. What investigation is done for CSF leak? For CSF leak, it is CT cisternogram. Cisternogram is what is done for CSF leak. You would see the white contrast in the subarachnoid spaces. Now let's identify the anatomy here, because this is very frequently asked in the exam. So what do you see on the CT PNS? This structure here, this is the inferior turbinate, and from there the projection coming, that is the uncinate process. Okay, that is the uncinate process. This one here is the middle turbinate. Okay, that's the middle turbinate. That is what we are seeing here. Look at this one. What anatomical variation is shown here? What cell is that? Is it the agar cell? If this cell, which I'm asking here, is this the agar cell? Is it the Onodi cell, Haler cell? What cell is this? This cell, which is the posterior most ethmoid cell related to the optic nerve. This is where you have the optic nerve. Remember, optic nerve cell related is the Onodi cell. Okay, that's the Onodi cell. This cell here, which is infraorbital, that is the Haller cell. Haller cell is infraorbital. This cell which you have, it is anterior most. You can see that we have not even reached the maxillary sinus yet. The anterior most ethmoidal cell, that is called as the agar nasi. Anterior matlab aage wala is the agar nasi, that is agar nasi. Has been asked in the INI-CET exam before. So how do you identify is, look at this air cell. This is the frontal sinus. Frontal sinus ke frontal recess ke bhi aage. Anterior to the frontal recess, the cell that we have sabse aage, that is the agar nasi cell. Okay, that's the agar nasi. All right. Okay. Look at some PNS pathologies. Important. What do you think is the diagnosis here? We see the double density here. The sinuses are not air filled. Sinuses have mucus fluid, and along with that they have this hyperdense element. So this is basically like the double density sign, suggestive of allergic fungal sinusitis. Okay, suggestive of allergic fungal sinusitis. Like you have the high density, the high attenuation mucus in allergic bronchopulmonary aspergillosis. You have the ham sign or the finger in glove sign. That is the mucus in the bronchi. Similarly, here in fungal sinusitis, remember we have the double density sign, the high density fungal elements. What do you think is the diagnosis here? What are these images showing? Anyone? What are these images showing? Just give me a minute. Lost the live chat. Just a minute. No, this is not the Pott's Puffy tumor. Are you seeing the bone which is destroyed? Pott's Puffy tumor basically is osteomyelitis. Right, the surrounding bone you should see is dirty. There is subperiosteal abscess which is present. Right, the bone should be dirty looking bone. It's not a dirty looking bone. Very good, Vandana. Absolutely right, Vandana, NS, Dr. Dancing Dr. Anjali, right. So this is a mucocele. Okay, this is a mucocele where you see that the frontal sinus is distended with a hyper intense structure, right? Hyper intensity with the thinning of the wall. This is a mucocele, your recent NEET PG question as well. The patient can present with proptosis, the frontal mucocele compressing on the orbit causing the proptosis. Okay, the patient can present with proptosis. This can come post-traumatic also. Parts from puffy, remember, will have the subperiosteal abscess which would be there. Next one, what is this image showing here? Right. That is the teardrop sign. So there is basically the fracture of the floor of the orbit through which the contents are herniating down. The teardrop sign, which is seen with blowout, a fracture of the orbit. Okay, this is seen with blowout fracture, the teardrop. And for the floor of the orbit, basically this is floor of the orbit. What X-ray view do we have? The Waters view, when you see the maxillary sinus also. Okay, that's the Waters view for the floor of the orbit. Teardrop sign. Next one, what sign are you seeing here? What is this sign here? The anterior bowing of the posterior wall of maxillary sinus. Look at this maxillary sinus. Look at this maxillary sinus. The posterior wall is bowing anteriorly. Absolutely right. This is called as the Holman-Miller sign. Okay, this is called as the Holman-Miller sign, which is seen with juvenile nasopharyngeal angiofibroma. Okay, that is seen with JNA, juvenile nasopharyngeal angiofibroma, where classically it is generally an adolescent male presenting with recurrent epistaxis. Right, the gold standard investigation is DSA. Preoperative, we can do embolization also with DSA, and the majority of the blood supply is via the external carotid artery. Okay, so this is JNA. Next one, what are you seeing here? First, tell me what investigation is this? This is the DSA. Whenever in angiogram you see a black vessel, remember black vessel is DSA. And what sign is it showing? Absolutely right. Very good. That is the Lyrace sign, which is seen with. So what is this Lyrace sign? Basically, you can see that at this carotid bifurcation, there is some contrast which is coming in, telling you that's a tumor there at the bifurcation of the carotid. So at the bifurcation, we have carotid body. So this is carotid body tumor, that is chemodectoma, which is causing the splaying of the two carotids, the ECA and the ICA. So Lyrace sign is basically the splaying of the ECA and the ICA. Chemodectoma, that is carotid body tumor, which is actually a paraganglioma, right? Which is actually a paraganglioma. And what sign do we see with paraganglioma on MRI? What appearance do we see? Because these paragangliomas are very, very vascular, right? Like you have glomus jugular, you have glomus tympanicum. These are very vascular tumors, highly vascular tumors. The salt and pepper appearance because of the prominent flow voids. Very good, Anjali. That is the salt and pepper appearance. Yes, it also gives the light bulb appearance. Okay, it also gives the light bulb appearance on T2 weighted MRI. The paragangliomas, similar to your pheochromocytomas. Okay. All right. Very, very important again and frequently asked. Where do you see the thumb sign? This is the lateral view. So epiglottis, inflamed epiglottis appearing like the thumb. This is epiglottitis. And this one, as in the recent NEET PG again, the narrowing here, that is the steeple sign. Okay, that is the steeple sign which is seen with laryngotracheobronchitis, that is croup. Okay, laryngotracheobronchitis, that is croup. Where do you see the thumb sign in the abdominal X-ray? Thumbprint sign in abdominal X-ray is seen in colitis, right? Ischemic colitis gives the thumbprint sign in the abdominal X-ray. Okay, ischemic colitis. All right. Next one, 3 images here. Tell me, what do you think is the diagnosis? The 3 pleural pathologies. So whenever you see this curve, right, it's not a horizontal line, it's a curve, the LSS curve. Where do you have the LSS curve? That is pleural effusion. Very good. Second one, where you have the horizontal level, the air fluid level in the entire hemithorax, it is hydropneumothorax. Hydropneumothorax, horizontal level. Next one, where you have the visceral pleural line, the lung collapse and surrounding it is the air without a vascular markings, that is pneumothorax. Very, very important, that is pneumothorax. If it is tension pneumothorax, that is hemodynamically unstable patient, that is hypotension, then the immediate management is the needle decompression, then followed by the ICD. If it is a stable pneumothorax patient, then in that case, what you need to do first is the taping, right? And then put the drain. Okay, taping and the drain is what we need to do. So you need to check whether the patient is stable or the patient is unstable. Next one, what do you think is the diagnosis in this one? Very good. This is pneumothorax because again you see that this is the visceral pleural line, this is the lung margin, and the black on CT, we know that what is black on CT? Black on CT is air, right? So this is jet black air without any vascular markings. So this is pneumothorax. Okay, so this is pneumothorax. What sign does pneumothorax give in the E-fast, the M mode of ultrasound, E-fast extended for pneumothorax? It gives the barcode or the stratosphere sign. Okay, the barcode or the stratosphere sign, most specific is the lung point sign. The presence of lung point is the most specific. The lung sliding is present or absent. The lung sliding is absent. Okay, the lung sliding is absent. Next one, another emergency condition very, very frequently asked, free air under diaphragm. This is pneumoperitoneum. Okay, this one is pneumoperitoneum, the free air under the diaphragm. Look at this free air beneath the abdominal wall on CT. This is pneumoperitoneum. First, of course, in any patient, always it's going to be resuscitation, stabilizing the patient, and then the patient is going to be taken up for surgery. First is stabilizing the patient always. And pneumoperitoneum, the best X-ray view is chest X-ray erect. If the patient cannot stand erect, then we do left lateral decubitus. Left lateral decubitus with a horizontal beam of X-ray. In pneumoperitoneum, what signs do we see? Asked in the last INI-CET exam. Remember, it is one of the important signs, the football sign. We have the football sign, the various ligament signs, regular sign is what we have, right? The inverted V sign, Doge cape sign, all those are seen in pneumoperitoneum, right? The cupola sign also. Next, now another important topic for INI-CET exam is a renal mass, a renal lesion evaluation. They change the image every time and they ask you which looks like a PYQ, but actually it's not a PYQ, right? So image A, image B and image C. Coming to the renal mass evaluation. First one is, what is the first renal lesion? So basically differentiating renal cyst from RCC from angiomyolipoma. First one is having the dirty black appearance. These are the dirty black areas with the vessels inside it. What has the dirty black appearance on CT? It is fat. Why? Because it has negative HU value. Remember, it has negative HU value. So when you have fat composition like this, it is angiomyolipoma, which is associated with tuberous sclerosis, right? Association with tuberous sclerosis. When you have a angiomyolipoma, remember it has the fat and it has a vessel and the muscle component also. So it will have the enhancing component plus it will have the fat component. When it is just the enhancing component with the solid component, it is solid enhancing lesion, there's no obvious fat. Then you think of RCC. In RCC, the history would be the hematuria ka history, right? There would be painless hematuria. And when it's a non-enhancing lesion, which is water density, non-enhancing is going to be renal cyst. Okay, non-enhancing is going to be renal cyst. What classification do we use? It's a Bosniak classification. A simple renal cyst like this without septation, no calcification, no solid component, it's a Bosniak 1 grading. Okay, that's a Bosniak 1 grade. So renal mass is another important topic for INI-CET exam. And remember, for this renal cyst, the Bosniak classification, this is done on contrast enhanced CT. Here, even though it's a cystic lesion, we are not doing ultrasound. We want to see the enhancement, so we do a contrast enhanced CT. Coming to the next one, what do you think is the diagnosis in these images here? Very good. This is polycystic kidney disease. Autosomal dominant or autosomal recessive? It is autosomal dominant. There is an autosomal dominant which presents with this well-defined cyst like this. Autosomal recessive actually does not have the cyst appearance. What appearance do we have in autosomal recessive? What appearance do we have in autosomal recessive? We have the sun ray or the striated appearance. Okay, the sun ray or the striated appearance is what we have in autosomal recessive. So here in autosomal dominant, these are the multiple water density cysts. Both the kidneys are enlarged. There are associated liver cysts also. Look at this. This is the CT scan, again showing the multiple cysts. This is the black bone wala MRI. It has the multiple cysts within. This is polycystic kidney disease. Autosomal dominant polycystic kidney disease. On IVP, what appearance do we get? Very good. That is the spider leg appearance that we get. Because in between the calyces, we have the multiple cysts coming in. So the calyces spread out. The splaying of the calyces because of the multiple cysts. Spider leg appearance. On the nephrogram phase, what appearance do we see? In the nephrogram phase, we would see the contrast in the kidney. These cysts are not communicating with the collecting system. So they will not have contrast. They will not take up the contrast. They will look like the holes in the kidney, like the Swiss cheese. Okay, that is called as the Swiss cheese appearance. Okay, they give the Swiss cheese appearance on the early nephrogram phase in IVP. And also remember the association of autosomal dominant polycystic kidney disease with berry aneurysms. Right, so we need to keep monitoring for the aneurysms. And for the autosomal recessive, remember the association with hepatic fibrosis. Okay, for that, remember the association with hepatic fibrosis. Okay. Next one, correct. It's chromosome 16 and chromosome 4. Coming to the next important one is the liver lesions. What is this liver lesion which I tell you is showing a hot spot on the sulfur colloid scan? Which is this liver lesion which gives a hot spot on the sulfur colloid scan? This is not hepatoblastoma. Very good, Kavya. Yes, Jitain, it is FNH, focal nodular hyperplasia. Okay, it is focal nodular hyperplasia. So basically remember that which are the liver lesions which have the central stellate scar? So if they tell you that there's a liver lesion with the central stellate scar, what are the two differential diagnoses? It is fibrolamellar HCC, fibrolamellar type of HCC, or it is FNH. Okay. Now, how can you differentiate the two? There are two investigations. One is MRI and one is the sulfur colloid scan, the nuclear scan. What will you see on MRI with the fibrolamellar? Because it is fibrotic scar. Fibrosis is how on MRI, T2 weighted MRI, it is T2 dark. Fibrosis is T2 hypointense. In the FNH, the central scar is the biliary radical, that is water. So it is T2 hyperintense. Okay, it is T2 hyperintense. Other thing, sulfur colloid scan is taken up by the reticuloendothelial system in the body. So taken up by the liver, the spleen, the macrophages. HCC is the hepatocellular carcinoma. It's a cancer of the hepatocytes, not the Kupffer cells. The macrophages are not there. So this will give a cold spot, not a hot spot. FNH has the Kupffer cells which are present in it, and that is why it gives a hot spot. Okay, that is why it gives a hot spot. So remember, this lesion which gives the hot spot is FNH. It is basically because of the presence of the Kupffer cells, which are the reticuloendothelial cells in the liver. Next liver lesion, the cystic liver lesions. How do you differentiate the various cystic liver lesions? Water density with thin wall. Water density with thin wall. This is a simple hepatic cyst. Okay, this is a simple hepatic cyst. Next, if it's water density but with a thick wall. Now the cystic lesion has a thick wall. So when it has a thick wall, along with the patient having complaints of pain, fever, there could be dysentery as well. That is basically a abscess. This is not the hydatid cyst. It is abscess. It has a thick wall. Abscess is the one which has a thick wall. Okay. So this is abscess, thick wall, peripherally enhancing. Next one, when you have the water density, the cystic lesion with the central dot, you can see the white dot within. That is basically the central dot sign. Within the liver lesion, there is a central dot sign. That is the Caroli's disease. Okay, that is the Caroli's disease, which is type 5 choledochal cyst. Okay, so that is Caroli's, the central dot sign, Caroli's. Next liver lesion here, what do you see is this liver lesion? So this is the triple phase CT which is shown here. Remember, triple phase CT is done for liver lesions. Okay, triple phase CT is done for liver lesions. This is not an HCC, guys. This is the classical appearance of a hepatic hemangioma. Okay, this one is a hemangioma. What is the classical appearance of liver hemangioma? Non-contrast, hypodense lesion, early arterial phase. There is just this nodular enhancement that you would see initially. When you take more delayed scans, you would see the contrast coming inside. Okay, the contrast filling the lesion. The centripetal filling of the contrast is what we are seeing. So remember, this is hemangioma, which is peripheral nodular enhancement initially, then with centripetal filling of the contrast. If that is the description given, even if the image is not given, the description is given. Remember, it is hemangioma. It's a very common liver lesion. Okay, it's the most common benign liver lesion. Remember, it's very, very common. Yes, I'm coming to HCC. Right, this is now what is HCC. This is now what is HCC. Why? Because HCC is supplied by the hepatic artery. The rest of the liver is supplied by the portal vein. So the contrast comes first into the hepatic artery, right? Aorta से पहले hepatic artery में आएगा, vein में late आएगा. So HCC is the one which will show the early arterial enhancement. So whenever you have a liver lesion with like early arterial enhancement and an early washout of the contrast goes out of it also very fast, right? That is a HCC. So look at the arterial phase. You see the enhancing lesion in the liver. When the liver is enhancing, then this lesion is giving away the contrast. It is becoming darker, right? And then in the delayed phase, it might have a pseudocapsule. In the delayed phase, it might have a pseudocapsule, right? So early wash in, early washout of contrast is what we see with HCC. Okay, that is what we see with HCC. Very, very important. You can also see in this patient that the liver margin is basically irregular. That is suggestive of cirrhosis. There is adjacent ascites also. That's the fluid density. That is the adjacent ascites also. Okay. So yes, that was about the liver lesion. So remember, renal lesion is also important for INI-CET. Liver lesion is also important for INI-CET. The next topic that we are coming to is the CNS infections. Quickly identifying the CNS infections. What do you think is this CNS infection here? Yes, what do you think is this CNS infection here? Meningitis, absolutely right. But what is the organism causing meningitis? Is this cryptococcal meningitis, TB meningitis, viral meningitis? Very good. This is TB basically. So in this image, what you are seeing, if I zoom in the image here, just a minute. Right. Look at this image here. So what we are seeing is this thick enhancement, the thick enhancement of the meninges telling you that the meninges are thickened, suggestive of meningitis. Look at the prominent temporal horns of the lateral ventricle, suggestive of hydrocephalus. Complication, meningitis ka complication, hydrocephalus. This is also where we see the hydrocephalus, and this is where we see the conglomerate lesion. Conglomerate means multiple lesions basically have come together. So in TB is where we see the conglomerate lesion, right, with the ring enhancement because of the necrosis. The basal exudates, whenever you get this term in the question, basal exudates, think of TB. They are enhancing. And what is this image showing here? This is the MR spectroscopy, which is showing a peak at this point between 1 and 2, around 1.3 ppm. We are seeing the peak at around 1.35 ppm, which is the location of the lipid. So basically, this is the lipid peak that we are seeing. Choline peak would be somewhere here. Lipid peak is somewhere here, 1.3 K aspas. So lipid peak, remember TB bacterium having mycolipid, that gives the lipid peak. Very, very important and frequently asked. So we get a lipid peak in TB. Okay, in neurocysticercosis, we get the amino acids ka peak. And TB is more common in the posterior fossa, cerebellum वगैरह में common आता है. NCC comes at the gray white matter junction very commonly, and there could be multiple. ठीक है नहीं. Choline peak is suggestive of a tumor. Choline is suggestive of a high cell turnover. The cell proliferation is very high. That is suggestive of tumor, a primary brain tumor. Okay, multiple CNS infections here. 1, 2, 3, 4, 5. Let's see who gets all the 5 correct. Write down in the comments what is 1, what is 2, 3, 4, 5. Okay. Then one is not neurocysticercosis. No, one is not NCC. Correct, Ashika. 5 is NCC. So in the 5, where you see those white scattered dots called as the starry sky appearance, those are the calcified neurocysticercosis. Okay, that is the calcified neurocysticercosis. Remember, when it is calcified, you need not give albendazole because the parasite is already dead. We need to give seizures ke liye drug, right? Because it can lead to seizures. Yes, very good. Yes, Anjali, 1 is toxo, where you are seeing the lesion in the area of the basal ganglia, which has this ring enhancing lesion. Uske andar bhi kuch enhance ho raha hai. So basically the ring enhancement with another eccentric target. So remember, this is called as eccentric target sign. Target sign T for toxoplasma. Remember, eccentric target sign is toxoplasmosis. It is basal ganglia most common site. Toxoplasma is an opportunistic infection. It is necrotic lesion. It gives the lipid lactate peak. Okay, it gives the lipid lactate peak. Second one is the soap bubble appearance in the MRI, right? Those multiple soap bubble appearance. Where do you see the soap bubble appearance? It is suggestive of cryptococcal meningitis. And what is the drug of choice for cryptococcal meningitis? Amphotericin B plus flucytosine. Okay, amphotericin B plus flucytosine. Next one here, where the temporal lobe is involved, temporal basifrontal lobe. Whenever the temporal lobe is involved, always think of herpes simplex encephalitis, right? As in the recent NEET PG exam. Generally, it is hemorrhagic encephalitis, and that is why the CSF will show the presence of RBCs. Okay, the CSF would show the presence of RBCs. Then we have this periventricular calcification. The calcification along the ventricles, remember it is CMV. That is the periventricular calcification. V virus, V ventricle ke along calcification. Remember CMV, cottage cheese pizza pie appearance. The baby can have SNHL is commonly seen. Petechae are commonly seen with CMV, right? So these are the various infections which are very, very important. Okay, very, very important. Next one that we have coming to the paranasal sinuses, the X-ray view, where you see the maxillary sinus very well. Remember, maxi is the water's view. Maxillary sinus is the water's view, which is the nose chin position. Imagine a glass drinking water touching the nose and the chin. So water's view, the nose chin position. This is the water's view with open mouth, which helps to evaluate the sphenoid sinus also. Okay, so which is called as Pyrads view. Water's view open mouth, that's the Pyrads view. This one where the forehead and the nose is touching the cassette. Forehead ke wahan is the frontal sinus. So what do we have for frontal sinus? We have the Cardwell's view. Okay, that's the Cardwell's view. Remember, in the Cardwell's view, you will not see the maxillary sinus because it is overlapped by the bone. In the Cardwell's view, we would see the frontal sinus. So this is the Cardwell view showing the frontal sinus. Okay, the Cardwell view showing the frontal sinus. Do watch that mnemonic video for the paranasal sinuses with the story mnemonic covering the orbit ke views also. Okay. Next one, coming to some important obstetric images, very frequently asked. This is the snowstorm appearance, which is seen with complete molar pregnancy. Right, snowstorm appearance, complete molar pregnancy. The treatment is suction evacuation. In the ovary, there might be theca lutein cyst because of the high beta HCG. For that, we need not do anything. Majority of the times, there is spontaneous regression. After the suction evacuation, there is spontaneous regression. What stage of choriocarcinoma it is when it is involving the lung? Right, the previous year question, what stage of choriocarcinoma it is when it is involving the lung? Remember, it is stage 3. Okay, it is stage 3 involvement. This one is the lambda sign, right? In the twin pregnancy, the lambda sign, remember lambda, laddu, that is lambda sign, laddu is lambda sign is seen in DD, that is DCDA, dichorionic, diamniotic. T sign, T is T wala, the most famous T wala in the country, respected Modi ji, right? So monochorionic, diamniotic is the T sign. Monochorionic, diamniotic is the T sign. This one very frequently asked. You don't see the calvarium here. The white bone surrounding the brain is not seen. This is the frog eye appearance. We don't see the brain parenchyma, the vault here. This is like the frog eye. So the frog eye appearance, absence of calvarium. This is anencephaly. Earliest anomaly identified on ultrasound at around 10 to 11 weeks, associated with folic acid deficiency, associated with polyhydramnios because the CSF goes out, right? And we need to do MTP because this is not compatible with life. Okay, we need to do MTP because it does not make sense to continue this pregnancy. And what will be elevated in anencephaly? What marker? What levels? Increased alpha fetoprotein levels. Right? So whenever there is a wall defect, a body wall defect, be it the abdominal wall defect or be it the neural tube defect, the spina bifida, that gives the elevated levels of AFP. Remember, in Downs, the AFP levels are down. In Down syndrome, the AFP levels are down. Right? Then we have the last image here in the obstetric one. What do we have here? This is the unicornuate uterus, right? Uterine anomalies is another important topic. So unicornuate uterus. On HSD, basically the confusion arises between bicornuate uterus and the septate uterus. They both look similar. We can differentiate on MRI or 3D ultrasound with the coronal images. In bicornuate uterus, remember it's bi. The inside endometrium, the outside surface, both are 2. In septate, it is outer surface is smooth, the inner surface is separate. So remember, in septate, S for smooth outer surface is what we would see in septate uterus. So that is how we differentiate the bicornuate and septate. In septate, the two cornu are very close together. In bicornuate, actually the two cornu should be wide away. But sometimes there's an overlap, and that is why in HSD we cannot say very confidently. The gold standard for uterine anomaly is laparoscopy plus hysteroscopy. Okay, that is the gold standard. The best non-invasive investigation is MRI. Okay. Right. So yes, that was about the most important images. What we have not included here, forgot to include, is the hemorrhages in the brain. Remember, you do get one question on that, be it EDH, be it SAH, be it SDH, or be it the diffuse axonal injury, which shows the multiple punctate hemorrhages. And for that, we do SWI imaging. SWI will be identified by the black dots representing the hemorrhage. The classical history would be a RTA patient with low GCS and the NC-CT is normal. That is what will be given. So we will do SWI MRI to look for the punctate hemorrhages of diffuse axonal injury. Right. So yes, that was about the quick review of the most important and the most frequently asked images and the questions in radiology in INI-CET. Right. Make sure you revise this very well before the exam. So when are we meeting next? We are meeting next at 8 p.m. Basically in the short INI-CET course, where it's going to be like another fast episode, few snippets from first aid, like including the colorectal polyposis valley syndromes, the brain tumors, right? So I'll share the PDF on the Telegram group. Okay. Diksha, what is the difference between caput succedaneum and cephalhematoma? Radiologically, so Diksha, in caput succedaneum, it can cross the suture, it can cross the midline. While cephalhematoma, subperiosteal wala, it cannot cross, right? So cephalhematoma would be more localized. So radiologically, like it was asked in the recent NEET exam also, it is more localized, right? Elevating the bone, and that is why the sign that is called here is, this is called as like the double skull appearance. The double skull appearance, and cephalhematoma is the one which can show the peripheral calcified wall. That is what was shown in the X-ray in the NEET PG exam as well, right? So it can calcify also over a period of time because it is more chronic. It takes time to get absorbed. Caput goes very soon. Okay, I'll share this PDF on the Telegram group after this class. And I hope, Diksha, that's clear. Okay. So thank you so much, everyone. Goodbye. Take care and keep studying, keep revising, and keep winning. Thank you so much. See you at 8 p.m. for short INI-CET.